Hello, everyone. It's my pleasure to welcome you all to this joint webinar organized by EMEUNET and PANLAR Joven, Young PANLAR. My name is Alejandro Gomez. I am a rheumatologist and researcher from Spain. I'm working at Vall-d'Hebron University Hospital in Barcelona, and I am also a current member of the EMEUNET Visibility and Global Affairs Subcommittee. For me, it has been a real honor to help bring together these two communities, these two networks of young rheumatologists, which are EMEUNET and Young PANLAR, for this collaborative session. We think this is a great, fantastic opportunity to strengthen ties between our communities and exchange knowledge, and also promote the education globally, global rheumatology education. I am now going to show the agenda of the event. So this will be the agenda for today, as you can see. Today we are going to focus on a fundamental topic, which is remission. Remission probably is the ultimate goal in the management of our of rheumatic diseases of our patients, representing probably the best possible outcome for our patients. However, the concept of remission can vary between diseases, and defining clear targets it remains an important challenge. So in this session, we will explore remission in two key diseases, which are rheumatoid arthritis and psoriatic arthritis, with the help of two outstanding speakers, which are Dr. Elise Mulligan and Dr. Andre Ribeiro. So before we move to other presentations, we will begin with an introduction to the two organizing societies, which are EMEUNET. Dr. Cristel Aguad are going to tell us how EMEUNET works, and then she will be followed by Dr. Wilson Bautista Molano, who will present PANLAR, and who will also be our co-chair for the presentation of this meeting. So hello, Wilson.
Hello, Alejandro. Happy to be here. A great pleasure to have this co-joint webinar and to discuss this very interesting topic.
Thank you, Wilson. Yeah, it's a pleasure for us also. So just a couple of housekeeping rules. Please turn off your camera and microphone as this webinar is being recorded. If you have any questions for our speaker, please write them in the chat, and we will address them during the question and answer session at the end. And during this session, you can also use, if you want, the raise hand button to ask your question directly. And lastly, we kindly ask you to complete the evaluation survey that we will share at the end of the webinar. We will remind it at the end. So let's begin. I'm very pleased to introduce our first speaker, which is Dr. Cristel Aguad, who will tell us a little more about EMEUNET. So Cristel, the floor is yours.
Thank you very much, Alejandro. I will try to share my screen.
Yeah.
So thank you very much for the kind introduction, and thank you for everyone for joining this nice webinar. And it really means so much for EMEUNET to have this opportunity to come together today and collaborate with PANLAR Joven. So who are we? So when I first joined EMEUNET, I was still a rheumatology fellow. And I was encouraged to join the EMEUNET working group. And here I am now, after 8 years, part of a network of passionate and driven rheumatologists who actually share a common goal of growing in the rheumatology field. So I really feel lucky to work with my amazing colleagues from different countries in Europe and more. So you may be wondering, who exactly are we? So EMEUNET, or the Emerging EULAR Network, is a EULAR community. So we are a European network of young rheumatologists and researchers who are dedicated to shaping the future of rheumatology. So it actually began like 16 years ago with an idea from 3 rheumatologists, Daniel Aletaha, Maya Book, and Laure Gossec, with a mission to widen collaboration, promote education among young rheumatologists and researchers, and eventually integrate them into EULAR activities. And this was more a project at the beginning, but actually over the years, it has developed into being a huge network of 3,400 members. And there's a structure. So as you can see here, there are 6 different subcommittees, members of these subcommittees, and leaders of subcommittees with 2 chairs and chair-elects. So as you can see here, the mainly the work is done by the 63 subcommittee members. And we have representatives all over Europe that we call country liaisons. And they also do many activities during the year. And also there's a meeting at the EULAR Congress with all the countries. So here is our structure. So we have Tuwe and Diego. So Tuwe is the chair, Diego is the chair-elect, and they coordinate all the activities of all the subcommittees. And first, we have the first subcommittee, the education subcommittee, led by Pierre-Antoine, with different activities such as educational opportunities, integrate EMEUNET member into the EULAR task forces, and they also do podcasts. And then we have the peer mentoring subcommittee led by Alvise. So doing a lot of nice activities such as the mentor-menting meeting at the EULAR, the peer review mentoring, which have been conducted for several years now. And then the social media subcommittee led by Siste Anne and Latika, which has been in charge of disseminating the word of EMEUNET through the social media, Facebook, Twitter, and now even LinkedIn. And we have the country liaison subcommittee led by Ertugrul, which is a vital link between the EMEUNET committee and the persons who are the country liaison, as you have seen just the slide before. And they collaborate in different ways. And this year, there's a competition, the Rheumavision competition, that will be highlighted in a EULAR session. And then there's the Visibility and Global Affairs Subcommittee that I am leading, which organizes many activities, such as this nice webinar in collaboration with young societies and other specialties. We also have many activities at the EULAR Congress, such as the EMEUNET networking event, the EULAR and ACR at the EULAR and the ACR Congresses, the EMEUNET booth, some meetings with patient networks, such as the meeting with PARE. And then finally, we have the last subcommittee, the newsletter subcommittees, which is very active with, it's led by Anastasia, with monthly newsletters released. So every month on a different topic, and do not miss highlights of the Congress, press review. And now I will quickly show you the different activities that we do. So here it was the nice networking event that we organized last year in Vienna at the EULAR Congress, the different societies that we collaborate with, the different meetings that sometimes we do from different parts of the world. Then here are our different social media platform, the podcast and the emails, the EMEUNews. Here it was actually at the Congress, the different activities that we do, such as the ambassador program led by EMEUNET members and the EMEUNET booth. And we also have different activities at the EULAR Congress, such as the EMEUNET Present session. So this year you can, I hope you will be able to join us at the EMEUNET Present session at the EULAR Congress in Barcelona. And there's also the mentor-mentee meeting done every year during the Congress. It's a live meeting with different activities. So finally, the Rheumavision competition that will be highlighted in a session representing different countries of Europe. And here are the different webinars that were done in collaboration this year, in collaboration with the different societies, and today this nice webinar. So here it's as you can see, so EMEUNET isn't just a network, it's actually a family. And we are here reunited at the General Assembly of the EULAR Congress. And I'm sure that we will keep growing, achieving many goals. And if you're interested, you can also join us through this QR code. So thank you very much for your attention, and I'm looking forward to the presentation on today's webinar.
Okay, thank you, Crystal, for the presentation. So I'm going to share the slide. Let me check at the moment. Okay. So I'm going to present and also to share the vision and also the objectives that we have inside the Young PANLAR group. We are a group of enthusiastic rheumatologists and also rheumatologists in training. We are starting in 2019 during an annual PANLAR meeting, collecting all of the enthusiastic people to increase our visibility as a young society, and also to spread the word about our activities that we have in the continent. So actually, we are almost 200 members in the society. Of them, 10 or 12 of these members are included in the steering committee. And we are growing in the number of activities and also with the interactions with other societies. First of all, we want to learn too much from the EMEUNET as a leader young society at international level. And for this reason, we are very happy today to start with this webinar. And we hope that it will become like an structure every 6 months that we have this kind of activities. What also we do, we are trying right now to increase the number of people, of young rheumatologists in all Latin American countries. So we are increasing our visibility. We are planning in the coming years to have like a special session of mentor-mentee in order to give the opportunity to all of these Latin American young rheumatologists to become more visible in PANLAR Joven, and also to increase the activities that we do. We are planning also to launch in the coming months like a survey in order to know the characteristics of all our members, and also to design a strategic plan to develop future activities in the coming months. So finally, I have to say that one of the most important activities that we do is the Copa America or American Cup. This is like a competition. Like this year in Mexico during PANLAR meeting, we will have the 5 version of this tournament. This is like a competition on question about rheumatology and general question of history, on health, of everything. So I think it's one of the most successful activities that we have done in the last year. And this is the reason of our congregation for all of us as PANLAR Joven. So that's all that I have to say about PANLAR Joven, and I know that it's time for our presenter for the topic today, Alejandro.
Thank you so much. Thank you, both of you, Crystal and Wilson, for such a clear and also really engaging presentation about both societies. And we truly hope that we see even more united and exciting collaboration like this between us in the future, because this is the main reason of doing this kind of activities. So thank you so much. And I'm going to introduce, I'm very pleased to introduce Dr. Elise van Mulligen. She's a postdoc researcher and epidemiologist working in the Department of Rheumatology in Leiden University. So please, Elise, you can start, and thank you for joining us in this super interesting webinar.
Thank you so much, Alejandro, and thank you for inviting me today. I will quickly share my screen. So I'm really happy to be here today. I can talk about one of my favorite topics within rheumatoid arthritis, namely remission. And I took the opportunity to talk about my most favorite topic, namely sustained DMARD-free remission within rheumatoid arthritis. And today I want to take you with me and part of my research, also from others, to understand a little bit more about the long-term disease control without medication. So I think everyone can agree on that the ultimate treatment goal in RA is to achieve remission, or at least low disease activity, in order to prevent structural joint damage and disability, and thereby making the life of the patients better and improve the quality of life. The ultimate goal is, of course, reaching remission. And due to the improved treatment strategies in the last decades, like early treatment initiation, treat-to-target approach, the introduction of biologicals, more and more patients are able to reach remission. The question then is whether we should continue the medication, or maybe we can taper or stop. At the point that the patient is in remission, it means that maybe the burden of treatment no longer outweighs the burden of the disease. As long as the disease is active, treatment is really helping. But if you are in remission and you don't have disease activity, you might only suffer from the consequences of the treatment, like adverse events, high costs, and so on. So therefore, it's good to reconsider, and maybe tapering treatment is an option for the patient. So EULAR recommendations agree on that. They state if treatment is under control for a longer time period, then you can consider dose reduction or interval increase in sustained when you're in sustained remission. And of course, if you are tapering your treatments, you can enter the state of DMARD-free remission. So the DMARD-free remission should be sustained, and the reason for that, I will come back to that in a couple of slides. So I will talk about sustained DMARD-free remission, and sustained DMARD-free remission is a combination of a sustainability criterion, so a time period, and also the remission criterion, so the absence of clinical synovitis, and that's all after the DMARD cessation. And SDFR currently reflects resolution of the disease chronicity, and is actually one of the best outcomes possible nowadays, and is even a kind of a proxy of a cure. So the concept of DMARD-free remission is indicated in this slide, and also the need to take into account sustainability is indicated here. So on top you see the image of persistent disease, in which a patient is diagnosed with RA on the left, then takes treatment, and then over time treatment is adjusted, but still disease activity comes back. In the middle you see a picture of someone who is entering a DMARD-free remission state. So at some point the medication is stopped, but then a flare is there, and then the medication needs to be restarted again, which means that the disease is still active and there's no disease resolution. Below you can see an image of the sustained DMARD-free remission, and here when medication is stopped, you can see that the DMARD-free state is sustained, and in this case you can really say that the person has a sustained remission. So I also did some research about this, and together with a colleague, we did a systematic literature review to find out what the actual prevalence of SDFR is currently. So we know we can taper, we didn't know what the average, how many patients can actually reach SDFR. So here we summarize it in this figure, where again disease activity is shown, then treatments, tapering of treatments, then DMARD-free status is reached. And what we found is that a lot of research is done using a definition of the time period below 12 months. So that means that they took into account 3 to 6 months, for instance, or only assessed whether the state was reached, and also below 12 months was reported. And at the end, you can also see some studies that really looked into sustained DMARD-free remission state, which at the end showed that the prevalence of SDFR was around 10 to 20%. And you can also see that this percentage is higher if you use a shorter time period, which might indicate that there are patients here indicated as being in SDFR, while there maybe can flare still. On top, you can also see the flares, and this is also nicely showing that the further you will be in the sustained state, the less flares you will have. So you have flares during tapering. This is the most risky phase of the reaching SDFR with high flare rates. If you have more than 1 year in DMARD-free remission, you have only 3% chance of a flare according to these studies. So the next step, of course, is then to see which patients can reach SDFR. And we also summarized this from the literature we investigated in this SLR. And we actually found that there is not really a clear answer to that. There's not a certain factor that's really important. We do know that from this you can clearly see that there's quite some evidence that RF and ACPA positivity is related to not achieving SDFR, and also, for instance, shared epitope and higher DAS at baseline are indicators, but they do not say everything. Then we know that we have the definition of SDFR explored, but how can we explain it? So where do we have to look for when we want to see which patient is suitable of achieving SDFR and who's not? So we can think of two hypotheses. The first one is the regaining tolerance hypothesis. Second one is the subgroup hypothesis. And what I mean with that is that with this hypothesis on the left, you can think of that the SDFR can be induced, so that over time you can give a person treatment, and due to that treatment, DMARD-free remission can be achieved by some patients, but some will not achieve it. In the subgroup hypothesis, it's more that some patients are eligible and some are not, and that will not change over time. So that means that intrinsically, those patients are not suitable to reach SDFR, for instance. So when you compare these two hypotheses next to each other, there actually is evidence for both of these, both for the predestination, both for the inducibility. And the answer is that probably when looking for subgroups that are most eligible for reaching SDFR, we should look into a combination of these predestination and inducibility factors. So we know from literature that ACPA negativity is positively related to SDFR, so that's an important factor. And I will also show you some other factors that we explored. So first of all, we looked into whether if the early referral results in more SDFR, and that was indeed the case. So what we did is that we compared the referral time. So we took this symptom duration and we compared when patients came early, so really early, less than six weeks between date of symptom start and when they came to the outpatient clinic, compared to later than 12 weeks. And with this, we saw that overall, more patients reached remission when they came early. And also if you compared early to super early to early, we also saw the same effect. So this means that the earlier the better for reaching SDFR. We also studied the disease activity score over time. So for this, we compared the green group, the SDFR. That means that in this group, patients who ever achieved SDFR were compared to the group of patients that never achieved SDFR. And in this, you can clearly see that those who ever achieve SDFR have a steeper decline in their disease activity score, which means that if you're looking for a predictor for SDFR, maybe we should look at patients who have a good treatment response after 4 months. And this effect was mainly driven by the ACPA negative population, as indicated here. And on the next slide, also the DAS at 4 months was grouped into categories. And what we can see here is that the lower the DAS is, so at 4 months, if the DAS is below 1.6, the higher the percentage of SDFR could be obtained, even till about 70%. And this is the ACPA negative population, I must say. But it's really stepwise. It means that, yeah, the more efforts we can do to lower this disease activity score, to improve the treatment response, maybe the better, the higher the percentage is that percentage of patients that can reach SDFR. Going back to the EULAR recommendations, I mentioned that they state that they advise at least that we should reduce the doses of treatment when patients are in sustained remission, but they never state that we should completely stop. And the reason for that is that there's a lot of evidence about tapering treatments derived from biological trials. So a lot of trials using biologicals are also investigating whether the treatment can be reduced. And of course, this is relevant because biological treatment is expensive and also can lead to a lot of side effects. And this results in that we are looking at a population that are in need for a biological, which might not be representative for the whole RA population. So in order to investigate this, we did a recent study in observational data, and we compared patients who ever used a biological during 5 years of follow-up, or 3, and compared it to the group of patients that ever used a biological. And the results were actually quite interesting, because in the group who never used a biological, the percentage of DMARD-free remission was about 40%. But the group who ever used a biological, the percentage was 0. There were none of the patients we included in the study ever reached SDFR. So that means that if you're looking at the current evidence, we might have to reconsider whether the SDFR is feasible for those who are using a biological, and also maybe the numbers. So we reported 10 to 20% SDFR in the whole RA population. The average might be even higher if you select the right patient population. For this study, we also stratified for ACPA, and then again, what we previously also saw is that the SDFR percentage is even higher in the ACPA negative population. So to conclude, I have some take-home messages. First of all, considering the high rate of flares after tapering, especially in the first year after DMARD stop, a DMARD-free follow-up of at least 12 months is advisable if you want to evaluate sustainability, and also in order to use SDFR as a proxy for a cure. Also, we saw that SDFR is achievable for about 10 to 20% of the RA population. But we also know that if you select the right patients with the right disease characteristic, with the right treatment strategies, this number can indeed increase. And all what I just presented is, of course, indirect evidence. And I think further research is indeed needed to determine the feasibility in more detail, and also to optimize strategies for further handling of this nice outcome for a lot of patients. And thereby, I would like to thank you for your attention. I will give the word back to Wilson, I guess.
Thank you, Elise. Very nice presentation. a very fantastic synthesis of the remission in RA. And I'm pretty sure that it will be a lot of questions that we are going to wait until the end of the session to ask for this question. So now we are going to move to our next speakers. And it's really a great pleasure for me to present one of the most promising rheumatologists in Latin America, my colleague, André Ribeiro. He is a rheumatologist. He's working in the Department of Rheumatology in el Hospital Clínicas and Hospital Molinos de Viento in Porto Alegre in Brazil. And he's going to talk about remission in psoriatic arthritis. So, André, the floor is yours.
Thank you, Wilson, and thank you, EMEUNET and PANLAR, for the invitation. I'm just going to share my screen here. Can you see it well?
Yes, we can see the
Okay.
screen.
So again, hello, everyone. Today I'm going to be talking about remission in PsA, which seems like a simple topic, but in fact, it's a very complex question to answer. What is remission in PsA? So I'm going to approach it almost philosophically instead of as objective as in the RA presentation, where we have criteria that are better established. So before talking about remission in PsA, we need to go over a quick introduction. So first, where does PsA fit in the SPI spectrum? As we know, PsA is a very heterogeneous disease that overlaps with features of both axial and peripheral SPA, as illustrated in this Venn diagram. Clinically, PsA can be highly variable. For instance, here we have images of arthritis, dactylitis, enthesitis, nail changes, skin changes, and so on, all of which may appear together or in isolation or even change over time. And if we go beyond the joints and skin, PsA is also associated with extra-articular manifestations like uveitis and IBD, and with comorbidities such as obesity, cardiovascular disease, and depression. All of these manifestations are driven by shared inflammatory pathways, and all can influence how patients perceive disease activity and remission. So all of these possible manifestations reinforce a key challenge in PsA, which is the fact that PsA is not a single phenotype, and that any definition of remission needs to really account for this complexity. So despite advances in treatment, when we try to assess how many patients really achieve remission in real life, we can see that we are far from optimal. This meta-analysis pulled data from over 14,000 PsA patients, and when using strict criteria like VLDA or DAPSA remission, the remission rates were very low, between 13 to 23%, depending on the criteria. And even when using more lenient permissive definitions like MDA and DAPSA LDA, the numbers were very far from optimal. So there's a huge disconnect between what we are aiming for and what we really achieve in real life. Because of these low remission rates, the topic of difficult to treat PsA is getting a lot of attention lately, and rightfully so. But before we can call a case difficult to treat, we really need to take a step back and ask, what does remission actually mean in PsA? Because the way we define remission, or fail to define it, directly affects who we label as difficult to treat. So before calling anyone difficult to treat, we need to first really define remission in PsA. And this is going to be the focus of our discussion for the next 10 minutes. This is the OMERACT endorsed core domain set for PsA, which was developed based on consensus between patients and clinicians. The inner core focus on all the domains that should be measured in all studies for all patients, reflecting joint and skin, fatigue, function, pain, and quality of life. The other two circles include broader concerns like economic cost, emotional well-being, sleep, stiffness, and fatigue, all of which influence disease perception and outcomes. And yet, most remission criteria that we usually use in daily life and in clinical trials focus on just a few of these domains and mostly from the domains from the inner circle. And it is easy to understand the complexity of trying to measure all of the domains that were approached by EMEUNET when we look at the amount of measures that we have in PsA. These are some of the metrics that we have. And for instance, in this Venn diagram, which is comparing almost all of the available metrics, we can see that some of them better capture some of the domains, while others better capture other of those domains. For instance, DAPSA is fast, very fast and joint focused. CPDI and PASDAS are more comprehensive, but very complex for daily practice. ASDAS comes initially from axial SPA and is used for the axial domain. And MDA, which is intuitive and target-based, is not a continuous metric to be used in daily life. And again, even those very complex and complete composite scores, even they do not cover all the relevant PsA domains. And some actually leave out major ones like skin or axial domains. And in fact, most of them leave out fatigue and other patient-oriented outcomes. So depending on which score we are using, the same patient may or may not be classified as in remission. And this leads us to the big question of what in fact is remission in PsA? Well, we really don't know the answer for that yet, at least, or we don't have a consensus about it. Is it the absence of swollen joints, the absence of pain? Is it the resolution of skin and nail disease, or the absence of power Doppler signal in an ultrasound examination? Or is it only when the patient says, I feel well? So for a disease with so many moving parts like PsA, defining remission with a single concept can be very complicated. And yet we need to define it because we need to treat these patients accordingly. So within the next part of this talk, I'm going to review some of the different proposals of remission. So let's start comparing the single versus composite scores. On the left, we see examples of single domain scores like tender joint count and swollen joint count, focusing on joints, inflammation markers, skin or enthesitis, like the PASI and PsA and the Leeds enthesitis. These are quick and easy to use, but miss the multi-domain nature of PsA, and we usually have to combine several of these to really assess one patient as whole. Composite scores on the right side try to combine multiple aspects of PsA, but even these vary in complexity and still don't capture every relevant domain. As I said, particularly fatigue, which is often missed, as well as long-term disease burden. So this contrast illustrates how no single measure or even these composite ones fully capture the PsA spectrum. And that's one of the reasons why our definitions of remission must evolve. And when we talk about the patient view, what is the patient thinking? In the real world, as well as in studies, many patients who meet clinical remission criteria still report pain, fatigue, and poor quality of life. And sometimes the opposite can be very true. Patients feel well, even if you still see some residual disease activity and might want to change the treatment. So there's a disconnect between the objective measures and the subjective experience in PsA. So even though we know that PROs are essential, they don't always align with clinical remission. For instance, this plot shows that fatigue is a key driver of discordance between patients and physicians. It shows that as fatigue increases in the x-axis, the gap between patient and physician global assessments of disease also grow from 0 to 4, meaning that as fatigue increases, the dissociation between the patient and the physician opinion also grows. So when we define remission only by clinical parameters, we are definitely underestimating disease impact. And this raises the question if we should focus remission on the absence of inflammation or by how the patient feels. We all know that it should focus on both, but it's really hard to achieving that ideal target. So with that in mind, we already know that there's definitely not a one-size-fits-all concept in PsA, because some patients have a more psoriasis dominant phenotype, some patients have more pain due to arthritis, and for some patients, even the IBD or the depression can take center stage. And even within one individual, we know that the dominant domain can shift over time. This other figure helps illustrate this concept. It maps how different scores measure different things. Some of the scores are better for the PsA phenotype, which is the persistent inflammatory-driven disease in red, while others are better for the NPsA phenotype, which is a more symptom-driven patient-perceived disease in blue. We can see that tools that measure inflammation like swollen joint count, tender joint count, and the composite scores tend to reflect more of the inflammatory phenotype of the disease, the PsA one, while others that are heavier in the PRO input, such as pain and global VAS, better capture this other phenotype, the NPsA, the non-inflammatory phenotype. So the right tool and the right definition of remission may depend on the patient's phenotype. And that's why the concept of domain dominant is gaining more attention in PsA. Also, if different patients need different definitions of remission, then imaging, especially ultrasound, offers a unique complementary perspective into disease activity. In this study, they evaluated how well common remission criteria like MDA and DAPSA identified patients with minimal ultrasound disease activity, defined as a power Doppler of up to 1 at joints, tendons, and epiphyses. And it showed that MDA and DAPSA have a low sensitivity for minimal ultrasound disease activity, roughly 35%, but also showed that it has a moderate to good specificity when trying to say which patients are in remission. But even though the specificity for it is better than its sensitivity, it is still far from optimal, and we are still missing patients. So some of these patients that we are missing may not have active inflammation, but still experience those persistent symptoms due to pain sensitization following a NPsA phenotype, reinforcing the idea that clinical and imaging assessments in PsA are not interchangeable, but complementary when we are looking at disease activity, remission, and trying to decide whether we are going to change or not our patient's treatment. Finally, even if we manage to agree on a definition of remission, we still have to achieve remission not only at a single point, but in a consistent way over time. And this matters because studies such as this one have shown that sustained remission, not just a one-time remission, is what really correlates with better outcomes. In this figure, it shows that those patients that maintain MDA over time have less radiographic progression, better function, improved work productivity, and better quality of life. So where do we go from here? I believe, as my personal opinion, that the next steps in the remission conversation should include defining better targets with consensus on outcomes that reflect PsA's multidimensional nature, integrating imaging and PROs not as optional extras, but as essential components of disease activity assessment, embracing longitudinal thinking and sustainability over snapshots and one-time point remission, and really moving towards a more personalized remission strategy using phenotype, patient priorities, and biomarkers to better assess disease activity. So to summarize, PsA is a complex multi-domain disease in which remission can't be captured by one tool. Each score has strengths, but also some blind spots. Imaging and patient perspectives often diverge from clinical scores, and we need to find a way to put all of them together. So a one-size-fits-all definition isn't good enough. Also, sustained remission is more meaningful than one-time remission. And most importantly, defining remission is not just about precision. It's about really aligning our targets with what truly matters to our patients. So thank you for your attention. I know that I brought up more questions than answers, but this is indeed a very complex topic. And when we think about remission, we should always think that remission should be the right target for the right patient at the right time. Thank you very much.
So I think it's time for closing the session. So I have to say, first of all, thank you for our both speakers, Elise and Andre, for a fantastic couple of presentations, and also for the synthesis and illustrations of the literature, and also to update of this topic that has a very important implication in clinical practice. And also to say thank you to all of the EMEUNET people, all of the John PANLAR people, especially Crystal, Alejandro for the organization of this webinar since we started last year for a couple of months ago. And now we are closing this very successful webinar. So thank you so much for all of you, and also for all of the people connected, not only in the Americas, but also from Europe and hopefully from around the world. Thank you so much, and hope to see you soon in our next co-young webinar between EMEUNET and John PANLAR.